This is a short tutorial for pediatric otitis media, otherwise known as middle ear infection. When otitis media is suspected, patients will have fever, recent upper respiratory infection, decreased feeding, drinking. Usually nighttime is very difficult. There's a lot of crying. But when looking at the eardrum, it's difficult to diagnose otitis media as being bacterial versus viral etiology, which we'll go over when we're talking about the management strategies. To diagnose otitis media, we're looking to see if the tympanic membrane is mobile. We can do that by using insufflation with the otoscope or using tympanometry. When air blows into the ear canal, the tympanic membrane should move slightly, but if it doesn't move, that's suggestive of a middle ear infection. Most children will have a middle ear infection at least once by the time that they are 3 years of age. And this is mostly a pediatric condition solely because of the anatomy. So adults are going to have more of a vertical position with the eustachian tube, and it's larger, therefore drainage occurs more easily. Where in younger infants and children, the eustachian tube is much smaller in size and it's more horizontal in positioning, making the drainage much more difficult. As I said earlier, a majority of cases are going to be viral. There's not really, again, a way to look at the ear and know one way or the other that it's viral versus bacterial. So the American Academy of Pediatrics has recommendations that address this. The new recommendations are the watch and wait strategy. Providers can give the prescription to the parents for antibiotics, but encourage them to wait at least 48 to 72 hours before starting the antibiotic, and only starting it if the patient still has symptoms. Usually by 48 to 72 hours, in cases that are viral, the patient's symptoms are going to improve or they're no longer going to be symptomatic. And that prevents them from doing a whole 10 days of high dose amoxicillin unnecessarily in the case that it was viral. So as I mentioned, amoxicillin is treatment of choice, 90 milligrams per kilo per day divided twice daily. If this antibiotic is not effective, Augmentin is a second line choice, and again, high dose twice a day for 10 days. Thereafter, third generation cephalosporins, such as Ceftonir, otherwise known as Omnicef, can be given. And if the patient is amoxicillin allergic, alternatives can be clindamycin or azithromycin, although both of those are not ideal first choices. Bacteria that tend to cause otitis media historically has been Streptococcus pneumoniae. However, with the Prevnar vaccination, the incidence of that pathogen causing infection is much lower. Remaining bacteria include Moraxella catarrhalis and Haemophilus influenza B. I hope this was helpful and that you have learned something about otitis media.